So that brings the International Association of Diabetes and Pregnancy Study Groups. There's a bunch of doctors that get together every 1 to 3 years and try to figure out better ways to care for women with diabetes during pregnancy. And they got together, you can see, from all over the world to try to figure out if we really should we not change the diagnostic criteria. So the IDEA PSG came up with 3 simple recommendations. First, let's diagnose everybody who's already got type 2 diabetes at the first visit. That makes sense, but that's new. That was the first thing. Secondly, this category that we already reviewed called pre-diabetes. These are people who don't make the criteria for fully type 2, but they're not normal. And they are 5 years away from having type 2. And they're saying these women tend to have fat babies. And let's check something about their glucoses, and if they're pre-diabetes, let's treat them like GDM. And for the rest of the women that after the first visit don't have any of those criteria, we'll give everybody a 75-gram oral glucose tolerance test using the cutoff values I just showed you, and we'll do it at 24 to 28 weeks. So you just check everybody at the first visit, and then the people who pass through that, then you check them one more time at 24 to 28 weeks. Let's see how that goes. First prenatal visit, ideally less than 13 weeks. Diagnose type 2 diabetes if it's present. You draw a fasting blood sugar and a hemoglobin A1C. Remember, hemoglobin A1C tells me how much frosting I have on my red cells. And if my hemoglobin A1C is above 6.5 or the fasting's above 126, I have diabetes. Everybody agrees with that. If I have the intermediate value with a fasting glucose at or above 92, or a hemoglobin A1C above 5.7, that's too many frostings on my red cells, we're going to call that patient pre-diabetes, and we are going to treat her like gestational diabetes, or at least that's what IAD-PSG says, and as a matter of fact, that's what Sweet Success says. For those who pass through, then you go to the 24, 28 weeks, 75-gram, one-step, 2-hour test. And if you trip any single one of those values that we show up here, any one abnormal value, then your patient has GDM. Okay, and here's sort of an outline here that we use at UCSD. It's basically the same thing. You see that they come in, we say if they're less than 24 weeks, then we get the fasting and the hemoglobin A1C. If they have a normal fasting and a normal hemoglobin A1C, we don't talk to them again from the point of view of this testing until 24 to 28 weeks when we give the 75-gram. If they get any abnormal values on that 75-gram, then they go get treated as gestational. Got that. Second one, for all the type 2s that have high hemoglobin A1Cs or high fastings, off they go. They're type 2s, and they go get treatment. And they sure need it, don't they? And then finally, the pre-diabetic group. This is the one that's kind of new on the game. Pre-diabetes. Going to have diabetes in 5 years unless we can intervene and give dietary counseling and help them out. And they're at very high risk for having a fat baby. We say if you've got these intermediate values, you get treated just like IAD-PSG said, we're going to treat you as gestational diabetes. Okay. What's the point about this hemoglobin A1C thing? That's kind of new to the game, isn't it? Well, I'll tell you. First of all, the variance, if you just take a person and draw 3 blood tests over the period of 3 days, you're going to get variations in fasting glucose that are pretty wide. And I think everybody in the room knows from looking at how people's fastings vary. I mean, they're not up all night eating. How come their fastings are so different? A lot of stuff affects the fasting. Hemoglobin A1C is buffered out because, you know, it's the last 90 to 120 days of frosting on the red cells. So it has much less variation and theoretically is more trustworthy or less fluctuant in terms of making the diagnosis. So any data to suggest that this is better? Well, there's one paper recently, 2008, that women whom the authors knew that the patients already had gestational diabetes. And they looked to see, could you just substitute the hemoglobin A1C using a value of greater than 6? Remember, 6.5 is the value for type 2, and 5.6 is the value for prediabetes. So they chose 6, and they found out, yeah, pretty good. It identified 87% of the patients with gestational diabetes. but there were some issues with it. Maybe they didn't pick the right level, I would say. It was a small trial, so it didn't change anything. So I think really that that the IAD PSG and therefore and thereby adopted Sweet Success guidelines have some smarts behind them. I think it's very logical. It's an opportunity to treat fetuses and make them better citizens, better children, better teenagers, better mothers themselves when it's their turn to go through a pregnancy. So I think it's, like I said, I'm very excited about it. But, as you'll see on those bullets here, that first of all, well, it's a brilliant thought, but nobody's really tested this idea. I mean, I've shown you, with the old rules of gestational diabetes diagnosis, and you treat those, it makes it different. But how about the new rules? How about these pre-diabetes people who are not that bad off, really? Does it really make a difference? Secondly, is it cost effective? You know, it's going to cost a lot of people out of their jobs and time to check their blood sugar, come to class, fax their blood sugars, phone in their blood sugars, receive calls, show up at clinic, take time off work. I mean, this is kind of important. As the Preventative Services Task Force likes to point out, is some of these interventions, like inducing people, and once you get called a diabetic, then people all start trying to manage you differently, so we may end up with unnecessary C-sections and things that, you know, we're going to be sorry that might have happened if we don't control it properly. So I think the whole cost effectiveness of treating of doing this early treatment of prediabetes women is left to be seen. And then, of course, long-term neonatal data, we have some from the trials that were done in Australia and New Zealand that show that children who were managed during pregnancy in their mothers have less central body fat. So they weigh a little bit less when they were born, but when they're age 8, they have less body fat. So there's some data, but it's not that great. So I think these are the concerns about widespread adopting of the Sweet Success guidelines. But here in the state of California, we have adopted them, and guess what? We have been using them here at UCSD for for more than a year. But I just want to show you in the first year that we adopted the change how things went. Because for 6 months, we were doing the old-fashioned way, and for 6 months, we changed over completely to the new way. So from January to June 2011, we did the two-step screening, and then we adopted the Sweet Success guidelines in June, and we took them through December using the algorithm that I just showed you. We ended up with 120 patients at the end of the year with gestational diabetes. Using the two-step criteria, you know, the patient population is the same group. A lot of people of various ethnicities. We have Caucasians, and you know, we have almost every nationality and ethnicity in our practice. And 3.8% of these were diagnosed using that traditional two-step. When we switched over, oops, now all of a sudden, and our diabetes educators brought this to our attention right away, is that it really doubled the number of women who were being told they had glucose abnormalities. And furthermore, they were being told early in pregnancy that they had glucose abnormalities, or many of them did. And now, you know, it's one thing to be told you have gestational diabetes when you're, you know, by the time you get to the class and everything, it's here maybe 30, 31 weeks, and she's, oh, okay, I can do this for a month. We're telling women now they're going to be checking their blood sugars for 7 months and calling them in and watching their diet and all this stuff. And then you can see that 2.5% of patients were diagnosed as having active type 2 diabetes that didn't know it when they checked in for their, and we didn't know it either, checked in for their first prenatal visit. So I think that's pretty exciting, and I like it a lot. Okay, but here's the kind of the way it went. And there's a couple little lessons in here. So you can see in the green stuff, this is the first prenatal visit results. And you can see that hemoglobin A1C picks up more pre-diabetic women than just the fasting alone. You can see that both together picked up 11 out of the 43, or about 25%, but half of the patients get picked up on the hemoglobin A1C. Now you say, oh, well, this is a bunch of false diagnoses. Well, for that little category, the row called A2-GDM means medication treated. These are people who needed to be treated. And look at what percentage of these 23 needed to be treated. Yikes. A lot of people. In fact, 2/3 basically of the people picked up in this range had to go on medication before the pregnancy was over. In fact, a higher percentage back here than the percentage here, where the people who were actually treated ended up being about 1/3. So that was kind of an important thing. The birth weights haven't shown much because it's been, we don't have that many patients in the group. So certainly we didn't save a lot of fatness here that we can see. We're looking at it, but I wouldn't say we've made a big indentation on the fatness business, but we definitely are showing that that medication is needed, because we don't put people on medication who don't have high blood sugars. They all had high blood sugars. So to summarize, for the first trimester patients, we found 43. The median, that means the most common gestational age at starting the medication, was prior to 20 weeks. And of the patients who were diagnosed with hemoglobin A1C alone, again, at approximately 20 weeks, half of them had already been started on medications. And so this is a group that, they're pre-diabetic. They are headed toward diabetes. So where do we go from here? Well, first of all, we urge ourselves to think long and hard about this. I think, I guess we like to say in California we're at the cutting edge. And after the IAD-PSG put out its recommendations, the people in the Sweet Success program gave a very long, detailed, if you will, contentious thought process to whether those IAD-PSG things should be applied to Sweet Success. And based on the things that I've told you today, everybody had reservations, everybody did, but everybody thought it's the right thing to do for babies, and especially babies who may themselves become mothers. The United States, I would not necessarily say everybody believes that. And some states in some areas have begun using these new testing criteria and others have not. In fact, it's such, and then ACOG, that puts out these guidance committee opinions, put out a committee opinion that said, we don't think there's enough data to change the system for diagnosing gestational diabetes, and we're not going along with it. So this stimulated the National Institutes of Health and the National Institutes of Child Health and Development to schedule a consensus conference to let's fight this out. Let's get the facts. Let's get it, and we'll get a pretty much blue ribbon panel of disinterested people to tell us what the right thing to do is. And guess what day, what 2 days the consensus panel was meeting? Right during Superstorm Sandy. So it was canceled, and it will be rescheduled in the spring, and I cannot tell you what will happen, but I will tell you that there is worry about the health care expense associated with having all these CDEs and all these women that now need caring for. But in my opinion, if you don't mind this editorial, but isn't this short-sighted? If we can, by intervention in a mother's diet, make a baby less fat at birth and be awful darn sure that that kid's going to be less fat in life, and if she herself has a pregnancy, is less likely to pass diabetes and obesity to another child, isn't that like the perfect, incredibly important, as good as a vaccination for varicella? I don't know the answer, but I wish you would think about it. We still need more data, and we're about to start a randomized controlled trial of either treating or not treating the prediabetes group, because it's not been done. We do need this cost-effectiveness data. We need to follow up mothers to find out how long it takes them to get diabetes compared to a control group. And of course, we need to look and see how the babies are doing. So in the end, I think it's a time of challenge and change.